We need to agree a chair this evening. So Councillor Rita Tada, does everybody agree that she's going to start the meeting? Yes. Okay.
Thank you very much, everyone. It wasn't meant to be a fait accompli, but circumstances have ended up that the mayor gives her apologies this evening, although she made sure this later. Welcome, everybody. Conscious that it's very hot and stuffy in this room as well. It can be. But also, acknowledging that a couple of colleagues actually feel a bit shivery. We may decide at some point in the agenda to take a break out of comfort. I know this meeting is due to go on until 9, considering the agenda items. I'm aiming to finish at 8:30. Let's keep an eye on the time. Welcome, everybody. Shall we do a quick round of introductions and then we'll dive straight into the meeting? So, my name's Councillor Rita Chudder, and I've taken over from Councillor Mia Wilson.
Christine Alsasser, Democratic Services.
Yeah, good evening. I'm Alan Adams and I'm the interim corporate director for adults and health in London Borough.
Hi everyone, Claire Gresham, interim director of Brick Health.
And I'm Diane Barron, I'm from Local Voice, and we've just commenced the delivery of Health Watch.
Dear Ivy, the other interim director of Public Health.
I'm Jerry Fraser-Wise and I'm the director in the Newham Place Partnership in the IC.
I'm Australian councillor for Forestgate North and new member of the I'm Montez Khan, Deputy Cabinet Member of Social Care, and I'm a councillor for Ministry of West.
Thank you. Have we got anybody joining us online?
We do. We have Tom Ellis, but he's not online yet. Oh, I need to let him in, sorry. And Lorraine Sandiza, who isn't here as well. And I see we have yes, that is Malik Nazir. Perfect.
Our colleagues online now, would they like to introduce themselves? Hello.
Hi, Tom Ellis, Director of Strategy, Newham Hospital.
Welcome, Tom.
Hello, and Andy Gold, Head of Food Strategy, on the agenda later on.
Were you in the room?
He was.
Okay. Is that worrying for you, Andy? Thank you very much, Andy. Right, okay, so I have got a script in front of me. I will say from the outset, I'm absolutely awful at reading off scripts. So if I digress, this will pull me back into line as well. Before we start, I'd like to pay tribute to Councillor Neil Wilson. Many of you know him for some time, and his sudden passing in July was a great loss to this council. And actually, in the few weeks that I've actually taken over from him, I can see how much he has done to improve health and wellbeing in this borough. And if you're agreeable, I'd just like for us to stand for a minute, pay tribute to him. Thank you. Apologies for this evening.
Just to notify on the agenda, there's just a few things that need to be corrected. So I need to put Claire and Adiola as the director of public health, and just that Diane Barham is here for Health Watch as well, just to make those notes. Apologies, we have apologies from Councillor Sarah Ruiz, Dr. Mohammed and Dr. Rima. That
Thank you very much. Do we have any declarations of interest? No? Thank you very much, everyone. Minutes of the last meeting was on the last meeting was held on the 18th of June. Has everyone had a chance to go through the minutes? Is there anyone who was at the last meeting that can approve the minutes? Yeah.
Last week, so yes,
Thank you. Yeah, brilliant. Item 4, and then now ICS update and the 10-year plan. I understand this is a standing item. Joan, would you like to take the floor?
Thank you. Few problems, but that's fine. So what you've got is in the published papers there is a summary report about the 10 plan. That came out in July. It's worth saying at this point, in terms of how that impacts the ICB as an organisation, that's still very much in working people. So this isn't, I can't say any more updates on what the future ICB structure might look like, or what that means going forward, other than what we already know in terms of the direction of travel for all integrated care boards, is that they become strategic commissioning focus, and that the delivery element of what we do currently in place eventually moves outside of the work of the RCB and becomes a kind of in whatever that vehicle is yet to be fully determined. So and we have no updated timelines on when that will be, other than Jim at the NHS England board saying that they're thinking about plan B.
Okay.
So that is it. So focus instead, as it should be really, is about what the 10-year plan is saying around the 3 major shifts from hospital to community, from analogue to digital, and from treatment to prevention. And there is a presentation that was circulated that summarises what those concepts are, but also gives hopefully a start to say that it's not that we're not already thinking about these things. So in Newham, we are, as a partnership, we are already doing lots of work, both individually and together as a system, to think about in particular hospital to community and our neighbourhood programme, and the work that's happening in actually it's no longer 2 pilots because the south of the borough is coming online as well in terms of what they want to do. So we've got work taking place across all of the shifts around as I say, what we need to be doing in Europe, where we see the direction of travel, how that's going to work in practice. So unless, and then what I will just say is, questions really well when we talk to it, is what was also circulated, which is currently confidential, is the ICB has been working on its strategy, that's the bit I can't find, its strategic plan and what that looks like in practice. We have to produce certain levels of plans by the end of this calendar year. There is going to be a requirement for a neighbourhood health plan for each place as well, but we as yet don't have any detail about what that needs to include or what that needs to look like, but that will certainly need to come back here for development, input, discussion. And the ICB, because it's moving as well towards commissioning, being the main commissioning body focus, you've been circulated a set of our commissioning intentions. So these have been shared with providers, but it's also we're keen to get comment and input to check that if there's anything missing and what those look like. I guess the only other point which is in the report, which I haven't mentioned, is people may have heard about something called an integrator. So each place is being asked by the ICB to consider what that function, how that function should be within their place. The commitment from Newham and all partners has been that we want to continue to do it as a partnership because we've got those great relationships. There is further work. There's no timeline, so there is plenty of time for us to do the further work. But the ICB ultimately will commission each place to have an integrator and that structure. But we are working through as a partnership what that looks like and how that could work in terms of be that some kind of mutual accountability framework together or other contracting mechanisms. But it's very early days as yet. And Simon Reed and Alan are linked in to that. Yeah.
Any questions, Joe? What people think are just priority. On page 2 of the report, you talk about kind of mitigating some of the risks. I appreciate how difficult this is for colleagues at the moment. You're working in an uncertain phase with an uncertain structure in uncertain times. But can you tell us anything about kind of the mitigations you're putting in place at the moment?
Yes, so I think it's an interesting time, as you say. So what is sort of happening is the requirement for ICBs to become focused on strategic commissioning is still there, even though the structure isn't following that. If that makes sense. So we're as an ICB, we're making sure that we take people with us on that journey. We take partners with us on that journey, which is why you've got copies of the commissioning intentions, circulated, open for comment, open for discussion. From a place perspective, there are significant challenges. The neighbourhoods programme is a big programme. The resource that we need to deliver that isn't necessarily here now. So in the future, if we're reduced in resource, that's going to be difficult. But actually, the partnership came together last Friday to talk about some of this, and there's a commitment from all partners to take seriously, to look at SROs within their own organisations for neighbourhood work, to look at the resources as a partnership. So I think some of the mitigation will come from the development of that integrated function, because there are a number of things that will be required of integrators and partner organisations stepping up together to manage that will lessen the risk of the ICB changing and ultimately replacing becoming something very different.
Colleagues?
Chair, yeah, thank you very much. There's a lot that's not specified, isn't there? So far.
Yeah.
So these, I would see that. I wonder what your comments are. I would see that as an opportunity for us to identify what's really in people will work in different ways. So identify what's really in the interest of you, and to shape and to put that into the structure of the plan. I'd just be interested in your comments.
Yeah.
And with the second, with the leadership role of this board in relation to joint commissioning integration, do you think it might be really good that the board takes a view on the commissioning intentions and the strategic shifts that the key organisations are trying to achieve? To look at them in the context, do they fit with what we're trying to achieve in the plan? I suppose that just before I pass over, sorry, because the 3 shifts, I think that's what I don't think any local authority would disagree with them. It's what local authorities have been trying to do for years and years. The issue is always, how do you do it? So maybe there's some freedom for us to do it in the way that's most relevant to you, and maybe the board can have a role in overseeing the plans of the organisations and saying, well, does that really fit with hospital to community, with prevention, right there?
Yeah, I think so. I think there are a lot of opportunities. I think thinking about the challenge of our population growth, thinking about outcomes, thinking about changes that there will be in primary care within some of this, and also it's a shame, Sue Wax and real set apologies, but you know, our PCNs are really stepping into this space now, but actually there will be significant changes in terms of how that delivery happens within primary care, because the ICB will, again, that's something that will be outsourced locally to places. The development of integrated neighbourhood teams will come with not with money, but it will come with a framework around it in terms of, and in that, exactly as you say, it's the flexibility for us to make sure we do that in the right way. The Health and Care Partnership Board does report into the Health and Wellbeing Board. Lots of us are the same members, but it's, you know, that's the engine room really, and this board absolutely needs to look at those commissioning intentions, which I can't even bring up on the screen because look at those and exactly as you say, be making sure they're the right things and done in the right way, and ultimately start thinking about what relationship we want, you want, this one's with the integrator function when it emerges. Yeah.
Thanks, Jo. See this as a really good opportunity in relation to 50 steps. So the 10-year plan of force prevention, that's what we're trying to do in 50 steps and have been for the last few years. So I just wondered what your thoughts were on how, as we progress, particularly given that the Health and Wellbeing Board is the owner of 50 steps, how we make sure that we are kind of aligning and doing it as one thing, as one approach, rather than ending up with two separate plans, one for the 50-step delivery and another for the 10-year plan.
Yeah, and I don't. So that's probably in the neighbourhood health plans, because I don't think we're necessarily looking at producing a newer answer to the 10-year plan. There will be elements that come from North East London that need to be commissioned. But that's our neighbourhood health plan. I think that we need to make sure we're dovetailing 50 steps into that. Definitely.
I mean, I can definitely support the move to more digital patient experience gathering, and I can understand the NHS app is a really good tool. I guess the worry is that the NHS will gather feedback from people using the NHS. It's not going to gain feedback from people using community services or adult social care, and there's going to be some big gaps. And I'm wondering whether that is going to then come within the integrator role. Is there going to be a mechanism that requires some of the providers to gather feedback from their users? And then how do we make sure that that's still got a level of independence? And how does it come back into one source of insight? I've got this, I worry that there's just going to be pockets of it everywhere, and it's not going to be person-centered, it's going to be patient-centered, which is two different things.
Yeah, and I very two different things. And my background is social care, so I'm very careful not to talk about patients. I don't think we know yet in terms of what the integrator may be required to do in that. And I also think that it's really important we remember when we're looking at what's in the 10-year plan, we remember the health literacy levels and the digital literacy levels of our population. And again, I think practically in the work that we're doing, we are trying to, you know, through the work that's done in the Health and Equalities Programme and some of those opportunities for funding, to think about those things in the neighbourhood programme and in how we're constructing things. I think systemically, we don't yet know what the requirements will be. But again, to Alan's point, that's where we have flexibility to build that in ourselves and make sure we have to do everything they ask of us, but we can do more and we can do it stronger and we can do it focused on the needs of our population.
Yeah, the thing I've seen coming out recently, I tend to forget the residents in the middle of it all, because there's so much going on that people forget I don't think it's intentional, but we just gotta keep an eye on it.
Tom, I've seen your hand up as well, and welcome Laura. Oh, sorry, they are there, trust me. Laura Eden from Education has joined us as well. Tom, I've seen your hand up. I'm just going to come in with one quick point, just following on from Diane. I also happen to be the cabinet member for transformation, which everybody thinks is digital, but it isn't. It's much more than that as well. I think it'd be good when those discussions happen to also tie in with where Newham is on that, because we deliberately got a caveat in each document that actually says we're conscious of the digital exclusion and capacity issues. However, that will decrease over the years.
Yeah.
And we've got to be cognizant of that as well. So it might be, this might be some synergies. And just on that basis as well, the local infrastructure forum where you're reviewing estates, is that solely NHS?
No, it's partnership. It has
LVN's on there.
LBN's on there. I can't remember.
That's fine. As long as LVN's.
Yes, yeah.
Oliver Judges.
Oh, it is on the judges, yeah, that's it, exactly. And Tom, Newham Hospital is chair, so he might remember names better than I do.
That's fine. As long as we're there somewhere. Tom.
Yeah. So first of all, just to second everything that Joe has said, I think there's a great deal of alignment between place partners in terms of our direction of travel. We've had a full hospital exec board review of the 10-year plan and looked at it in relation to our clinical strategy, which was agreed last year. And one of the 3 key pillars within that was around, we've called it in the strategy, dissolving traditional boundaries between partners, between, I can't remember, I should know this because I wrote it, but between, in essence, it's acknowledging that with the population growth in Newham, neighbourhoods is one of the key, if not the key, way that we're going to mitigate growth in demand on the hospital at a time when there isn't a huge amount of capital investment available to expand the hospital to meet that growing demand. Bearing in mind the hospital was built with a population of circa 250,000 in Newham. It's now, depending on your metric, 350 to 450,000. And then we have an ED that's too small for current demand, let alone population growth. So we're really focused as a hospital on the neighbourhood model as a way to better deliver care and sustainably deliver care in the longer term in Newham. I suppose the other point is just, someone mentioned that much of this is a council's been trying to do for a very long time. I think if you look at it, you could say much of it the NHS has been trying to do. The challenge will be is what are we going to do differently over the next 5-year period to actually make some of this a reality. I think it's a really tough ask.
Any other points anybody like to raise?
Yes, just on the strategic commissioning plan that's going to be developed, what kind of things is it going to look at, and is there a timeline on it?
So yes, so we have to put in the plan has to go in by as I say, the end of this year. So that's why the draft is circulating now. The commissioning intentions are grouped by community, unplanned care, urgent emergency care. And there's a diagram in the packs that you've got circulated, which shows the different levels and the different subject areas. It won't be in your published pack. It was circulated as a supplementary. And clearly none of us can find it. So that's fine. But yeah, so there's a number of key things that it will pick up that it has to cover. If people haven't got it, then we can recirculate that. But it's really important that we do. This isn't going to be the only chance to look at it, but these are initial thoughts that anyone's got or any comments on it. Please let me have.
Is it worth us setting a deadline for collectively partners to get back to you
Yeah.
with comments on the commissioning priorities?
It is. I haven't. I'll even get to my emails. So I and my memory and that age. Yeah, so let's say, I think a fortnight is plenty. Because you time to all look at it and you time to collect, so.
Chris, would you be able to send that out again to everyone with the deadline and comments directly back to you?
Yeah. Thank you.
That's really helpful. I would just also say somewhere on the presentation, it says something about the NHS rewarding healthy living by giving people points and or incentivising or something. It was in the presentation somewhere. And just to say, actually, Newham Council's already got a system for incentivising under its leisure contract. So it'd be really good actually as these systems progress to think where can we actually make savings by joining forces.
Yeah, and that's where, to Blair's point, the devil's in the detail of how we implement what's in the 10-year plan.
Yeah.
But so although they're called neighbourhood place plans because it's all about neighbourhoods, but that is ultimately the Newham place plan. That's what we do. Yeah.
One final question. Given that most of the public sector at the moment is frantically beavering away around budgets, what's the NHS? Oh, well, how are you managing with budget setting at the moment?
Difficult. That's why we're making 50% cuts.
And
And why we're doing the commissioning. So what's the process? Tom might be better placed to answer that. So there's a few breakthroughs because each provider has their own. They manage the ICB, then looks at that as a whole. There is financial planning happening currently. NEL ICB has a very hard target to hit. But that is also the commissioning intentions and some of the work that needs to take place. So the way the NHS has historically worked is on block contracts. So work is starting with urgent and emergency care to look at how we start to unpick those block contracts so it becomes easier to start looking at financial savings and also start making the shift that we're talking about from acute into community as well.
So as councils have a deadline in February usually, or
with
back
the NHS.
yours is February as well?
I don't know off the top of my head because I'm looking at you, Tom.
Yeah, no, I can see you're looking at me. End of March for the NHS and the process around 26-27 budget setting is literally starting now. So it's incredibly early days for it. If I'm being honest, at the moment, all the focus is on trying to hit the 25-26 number, and that's an incredibly difficult number to hit in and of itself.
Indeed. Councillor
So considering the 50% savings, how does that impact your early intervention work, like prevention and initiative, like, you know, the smoking, the vaping, all of that?
So that's a 50% saving in ICB resource. So it will impact in terms of who is available to work on all of the things in the 10-year plan. But that's some of what we talked about in terms of how as a system we start to come together and look at, you know, who's doing what. And so the 50% savings is an ICB target around resourcing.
Done this, the early intervention work that tends to get.
Yeah, but I don't know what I don't know the detail of the restructure. We are waiting and have been since March.
The council has a budget scrutiny commission that meets annually before our budget is kind of set, and I was privileged enough to sit on it last year. And one of the things we discussed, and one of the recommendations that's made to the council, is that we should be more open in our discussions around budgets with strategic partners, NHS, the hospital, ELT as well. Is there a space for that in the current climate? Are there opportunities for that?
So that has happened. So the Newham Healthcare Partnership Board has had a little while ago now, but there was a workshop where everyone brought their savings plans, their financial challenges. So yes, so the partnership board does talk about that. It talks about individual organisation priorities and how as a system we can work to together on those. So yeah, I would say that's the health and care part.
So there's a forum and an opportunity for that. Is that a document that this group could have sight into? Bear in mind there may be issues of
There
confidentiality.
might be, so I would check. It's a little out of date, but I can certainly share the broad principles of what was discussed.
And my thinking behind that is that if we do have access to that document, then it helps us thinking about, informs our thinking about finishing priority.
But yeah, I mean, yes, but thinking about commissioning priorities, is really important to also look at then the commissioning intentions of the ICB, because that takes those financial elements into account with provided as well.
Diane.
And looking at the 3 shifts, and we know generally that hospitals suck up all the money, don't they? Is there a plan to actually say we're going to spend this percentage on prevention and this percentage on actually getting new technology and investing in equipment, modern computers and systems for people, or are we going to sit around and say the hospital has sucked up all the money?
There's no detail in terms of that within the 10-year plan. But in terms of
flexibility,
the hospital and the acute, that is the whole premise behind neighbourhood working, community, the shift from acute to community, the work we're doing with NUH to look at, they're part of developing neighbourhoods, they're part of, so that at the moment is the whole crux of what we're doing to actually support that.
Can I just?
Is it possible to
Can we-
is it possible to know how much is going into hospitals now, how much is going into prevention, and how much is going into
Yes.
AI? Because that would be interesting.
Tom, you want to come in?
Yeah, I mean, it's fair to say over the last 20 odd years, the percent spend in the NHS on acute care has gone up. It's also fair to say that actually the new 10-year plan is explicit that the spend in the acute sector will fall as a total percentage of NHS spend. So we as a group of hospitals, and Newham as part of that, are working on the essential premise that it's going to be a flatline position for the rest of this parliament, if nothing else, which is going to mean, in effect, we're going to have to significantly reform the way we deliver services just to keep delivering services that to a level that people would rightfully expect from their local NHS. So your premise is fair looking backwards. I don't think it's right looking forwards.
Thank you. Anything, any other questions? Actually, did you have a hand up, okay, on that basis, so we've got an action which is to all respond to the commissioning priorities, and I think obviously you will feedback back through officers. And then are we happy on that basis to know the details? And I think this is an ongoing discussion, it's a standing item that will keep coming back. Are we happy to note that for? Thank you very much, colleagues. Okay, moving on to item 5, which kind of nearly dovetails in, like we planned this, isn't it? Azzy, you want to take us through some thinking around the opportunities for neighbourhood working?
Yeah, thank you very much, Councillor Chada. So this arose spontaneously, but is based on the opportunity that those changes in the NHS afford us to think differently about how we as a board are formed and how we operate going forward. It also thinking, and again, this neatly leads into Claire's piece with the 50 steps. The 50 steps is a really rich and ambitious strategy. It, like a good health and wellbeing board strategy, covers the whole of the life course and all of the determinants. This board has the potential within its governance arrangements and its ways of working and its membership to be able to have conversations as rich and helpful as the one we just had across a number of topics, which we also have the scope to prioritise. It feels like now is a good time for us to think as a group and invite some wider stakeholders to be able to reshape how this board is set up and how we think about focusing on our priorities in order to be able to be that democratic support for both the council and the NHS and the health and wellbeing of our residents in the new landscape against some quite steep challenges. So the proposal is that we have a development away half day, that we workshop that and that we think about reforming the membership. Out of that workshop, we bring forward a series of options or proposal to be signed off at the next health and wellbeing board meeting in January.
So obviously this is a proposal for done for a year, so we're all sort of supportive of it. So it's really up to comments online, Joe and I, if you'd be supportive of that and if you'd be able to contribute the resources. I know time is tight for everyone, but we really think that this would be a good investment of time and set us up for the future in a more productive way. Yeah. Tom?
Yep.
Brilliant, thank you very much. Well, we're racing through this, folks. We are racing
Thank you.
through this. Thank you very much. Adiola, you'll come back to us with
Yes.
additional dates and do all the diary stuff and everything.
Yes, I'll liaise with Christine if that's okay.
Thank you very much. Oh, do I have to get people to vote on it?
No, it's just for noting.
It's the noting, yeah. We're all agreeing. We're in agreement, yeah. Now it's over to what was labelled on the agenda as Health Watch, but should be Local Voice. And I don't know, Claire, if you want to say a few words about Health Watch and the last piece of work you do, which has been tabled as a report on stop smoking. And then
Don't mind talking through it, yeah. Because I got the Charlie to give me a briefing.
Absolutely. It
Yeah.
may be easier from I can add any additional context afterwards from my other smoking work, but yeah.
Yes, thank you, Jack. So I should explain. So it should still be Health Watch, newer on the agenda. It's just that Local Voice is now the delivery organisation rather than CV Plus or Community Partner. So the contract's moved to a different provider, but the staff have 2P'd over. So it's still the same staff. It's kind of, everything, sort of the people on the ground are the same, but I guess the management and the way we structure it is slightly different. So Bashari was supposed to be here tonight, but she couldn't make it. And it was actually Jemima who did a lot of the work. So I'm a bit of a fraud showing up and taking the credit for it. But that's where we are. And they've given me a bit of an update on the work that they've done. They were obviously focusing on South Asian and deaf communities, and they had conversations and workshops around cultural, linguistic and communication barriers affecting the access to smoking cessation support from those groups. There's some key outputs in the report. 3 key outputs. First, the team completed very brief advice training, which means that they were able to provide outreach activity and have supported evidence-based conversations. They piloted a smoke-free outreach stall outside Stratford Centre, which I think was well attended. There was supposed to be one today, but they never provided the tables. But I think it proved to be a very useful way of engaging with people. And they've been collaborating with Quitwell New, which I think has again been a really useful partnership. It did focus on groups most affected by health inequalities, and again using the sort of framework of accessible, relevant and trusted. Trust kept coming up as the most important issue in establishing relationships. From the South Asian community, we learned that social norms, family influences and stress play a big part in smoking habits. We also saw growing use of vapes and cigars, which is concerning, which people see as safer alternatives. The deaf community had a strong preference for BSL videos and easy read materials. Just on that, I guess, certainly Jemima said, not everything went smoothly, and engaging through the faith centres was more difficult than expected. And they're still working closely with the community connectors on that, but again, there's issues around trust and building those relationships. Interesting, a common barrier faced was the perceived stigma around smoking, particularly with faith-based communities. In some settings, smoking may be viewed not just as a health issue, but as a moral or personal shortcoming, which made conversations uncomfortable or even taboo. Individuals might worry that admitting smoking could lead to judgment or social exclusion, causing them to avoid participating. And interesting, Jemima was saying that it was much more successful when they talked about quitting smoking alongside a whole range of other activities. So don't do a quit smoking, event, do an event in which quit smoking is part of it, so that people aren't necessarily seen as being sort of weak and have, weak willpower. So that's something that they're focusing on moving forward. And this is something that we've certainly seen. We've just done a wider piece of work across North East London around the Eastern European community and some of the issues there about people perceiving quitting smoking as a issue with poor willpower, and that if people have they can give up smoking, and if you can't, then you're weak, and they don't really see quit smoking services as something that can support that. So I think there's some interesting work to be done around it's almost you need to take a look at it from a mental health perspective as opposed to you can just quit smoking perspective. So it's something we'll continue to work on, I think, in the future.
Thank you. Councillor, I'm just looking at page 34 in the house copy. So in terms of targeting the groups, have we missed out young people and vaping? What does it look like in terms of, I guess we're working with community organisations, physically.
As I understood, the young people weren't focused at this piece of work, but there is another piece of work going on around building a group of young people around Health Watch. I'm also not sure, I don't think this one focused on vaping, did it? And I think vaping is much more of a sort of prevalence in younger people, although I do think they're going back to smoking again now because I think it looks cooler. But there's some information that they don't smoke for as long, but yeah, I think again that's a gap, and that's probably something. Okay.
Thanks. And I have a question, Diane, but also in terms of just this point, we this work is very much part of a wider local tobacco control plan that we have. So this particular project is one of a number of local voluntary and community organisations and Health Watch who were funded to do some targeted work with particular communities, and so the different organisations that received grants targeted different parts of the community, and it's the first time we've done this, so it's very much about testing out the model, and also gathering some of these really valuable insights, such as those that Diane's just touched on, that we can then use to inform not only this kind of work in the future, but also the way that we're delivering other types of stop smoking services. So it's sort of I think useful to note that this is one very valuable project as part of a wider strategic plan we have around tobacco control. Diane, I just wondered, my question was, it sounds like you've not only done some great work, but had some really good sort of legacy from this in terms of the training that the staff did, and the experience that the team has built up in doing this kind of work. And I wondered if you're able, beyond the scope of this particular project, if you're planning to then continue this type of approach around smoking or other sorts of issues.
Definitely, it's something The work program, I think the board agreed with the previous, Health Watch members. I think we're still going to stick with generally within that work program. But there's issues in there around health literacy, health campaigns, and I think smoking fits within that. Actually, just understanding a lot more about how you have different approaches, how there's different beliefs, not only culturally but religiously, or young people, for instance, why they do these things in order to target your initiatives to meet those specific reasons rather than having general campaigns, and just how they can all be different for different groups but reach the same outcome. And that's the same, I think, for winter camp, and backs sort of thing. What is it that we need to know about reaching those people to have they achieve an equal outcome? And it's really fascinating how different they all are. But yeah, that's definitely something we'd like to carry on working on.
Alan.
Yeah, thank you, Diane. That's really, really interesting. And it's also quite complex and difficult, isn't it? I think so. There's obviously a lot of the intention is to learn a lot of things. Part of it. So I'm wondering how much it's also based on things that has already been learned and is best practice elsewhere. And the second thing is, I know this is difficult, but and I know you're trying to find out what works, but what do you have in terms of evaluation, in terms of people quitting?
Yeah, so I think that's a really important thing. Firstly, I think it would be great if we can get the insights from the other projects as well, so that we can look at that. I think our approach is never go out and gather information until you know what's already out there. There's nothing more annoying than being asked the same question again. So it's about what do we already know to figure out what we don't know, and then focus on the what we don't know aspect of it. And I think, yeah, that's certainly what we'll be focusing on moving forward. What was the second part of your question? Evaluation. So again, I think setting out at the beginning, setting a baseline and saying, well, the quit smoking program, can we actually make sure that we are gathering enough equalities information to know who's quitting smoking? Are they actually gathering? So at the moment we've had, white other as a category for people giving up smoking, and that could be anybody from, a New Zealander to a Ukrainian to, it doesn't tell you enough about who those people are. So just making sure we're getting the right information to evaluate how many Romanians gave up smoking last year and how many have given up this year, and to be able to do that evaluation, I think. Start gathering the right data.
That's so. Diane, I'd like to have at the beginning. I'm very excited to be able to think about how we might join up around knowledge management, but also thinking about evaluation, particularly when we've got these fairly complex interventions of multiple different voluntary community faith partners, multiple different points of contact, and how we can think about standardising or supporting around and getting sense from it. But I agree. I'm very excited to hear your approach around outcomes, your approach around granularity on ethnicity, your adoption of the art framework. It's super exciting. So looking forward to that.
Did have the document that's attached, the Health Watch new the slide deck. Can I just check, is that a template that new colleagues provide Health Watch to complete? That's right. Yes, exactly. Yeah. So when did the grant start?
It's this financial year. I'm not sure exactly at what point the project started, but it was part of our
this financial year. And has the project completed, or is it still in progress?
The grant is completed, hasn't it? But the project's sort of ongoing. So yes, we're continuing it, but the grant's completed.
I'm going to be a little bit pushy on this and take your prerogative. There's a mixture here of outputs written where outcomes are and outcomes written where outputs are. Now, I take on board fully that there is challenges around methodology in evaluating a health intervention that you might not actually know the outcome for long term as well. But can we collectively, maybe not right now, but at some point, put our minds to what is, as Alan said, the best evaluation framework? Because being perfectly honest, this to me at the moment reads like a very good narrative of interventions that have been done. But in the time where we've got to justify spend, would we do it again? I don't see anything in these papers that allows me to defend this as ongoing expenditure.
I would just come back and say that moving forward, I'd like to do everything under a theory of change where perhaps partners start out by, so we set out at the beginning what it is we want to achieve and everybody agrees that. That means the people collecting the data at the end of it, we agree that that's what we want to achieve and then we can work backwards from that. And then we know exactly what we're aiming to deliver and everybody's accountable for it because I can't count how many people quit smoking, but somebody else in the partnership can.
And it might be we can't actually count the number, but we can gauge it in another way as well. Sorry, Claire.
No, just to add that the part of this project is about referring people to Quit Well Neuro, which is our stop smoking service, and we are able to monitor the data from where those referrals are coming from. So that is one of the hardest outcome measures that we have for monitoring this kind of project, where we can see how many people came from a health board.
So,
There is so on output 3, it says we're currently waiting for the number of referrals from the Quit Well Neuro team. Could we get that for the next meeting so we can complete the circle? Yeah, complete the circle, complete the square, whatever the analogy is, so that we finish off the discussion. Sorry, Anne.
I was going to say same thing, yeah. So, yes, just so we can. I mean, plus, okay. So I was going to say that also. I imagine there are ways. You can't maybe ways that you can imply or assume or might be other supporting evidence that suggests that this has had an effect. So I think because it must be difficult to measure, but certainly how many Romanian people or whatever have been referred as a result of this would be a hard measure compared to what was happening previously. But maybe there are other ways as well to evidence that is slightly tangential but helps build the effect. Because it is the case, isn't it? Everything we do, we have to know, okay, did that work? And obviously the project you did, you did it to learn at the end of it, did this work? So I think that is quite a really important focus.
Sorry, there's an interesting statistic out of the Eastern European work we did where I think only a quarter of people who said that they wanted to quit smoking said they would use a quit smoking service.
Yeah.
And you're thinking, what the heck are you going to do there? What can you do then? And I think, half of them might have even said that, there was a huge percentage who said they weren't even interested in giving up, but the ones that were, only a quarter said they would use the service.
That's really interesting.
Yeah.
I think it's data and insights like that help us collectively to shape the next iteration of these services. So please don't take it as a criticism. I'm just thinking about how we collectively push forward on some of these issues together. And I think the other thing as well is to say maybe there should be a section 5 on this, and that actually says we're uncertain as well. There's nothing wrong with saying you're uncertain, as long as you acknowledge it, because to the lay reader reading this leaves more questions than it answers. And I think sometimes that, especially in the current climate, that can be really off-putting for lots of people as well. But good piece of work. Got any other questions?
Just through just to add to it, really, I sense there's more that's been learned than is in this document at the moment. It'd be really good to know that. I think
It'd be good when they all come together and all different.
That's
something, wouldn't it? Yeah.
And in the previous years, we've had items at the Health Wellbeing Board about our overall approach to stop smoke, to tobacco going and vaping. And so if the board would like, we could have a larger item come back where we bring together the sort of the full range of different avenues we're taking that sort of collectively add up to having different impacts in different communities and so on. We can do that.
I presume that's a collective decision the board can make. Yeah. Is that something we'd all like? Mm-hmm. Yeah. What would you like to take that for? I'm not putting you on the spot, but when it's comfortable. It can be next financial year as well. If that's
Well, it could be. I mean, we it could be for the next meeting, but if we wanted to do it, the next meeting might work quite well because we have a specific grant from the Department of Health and Social Care that we have to spend on this work. So if we brought it to the next Health and Wellbeing Board meeting, part of the purpose of that item could be about exploring proposals for how that money is spent based on the evidence we've got from the first year or the first 2 years of that grant in terms of the essentially what outcomes we've achieved through the funding and therefore what that means for the next year. So that could work quite well to do it before April.
Okay. Deal. Thank you very much. Good question. Anybody online with questions now? Okay, right, let's crack on then. I'll be happy to accept the contents of that report. Yeah, thank you very much. Thank you very much. Dan, I want to give you an opportunity. Is there anything that you want to say about local voice? As you join us here in Newham, or is there anything that arts can help you with?
I guess the thing about local voice is that we're very, very we like to emphasise the work being based on evidence of community insights, and we're very we focus a lot on taking what people have told us, coding it into a coding matrix that then allows it to be sucked out again and used in a whole range of different ways. So it's a bit like taking qualitative insights, turning them into quantitative, and then flashing them in front of GPs and clinicians so they can actually measure change over time and hold them to account. And then again, trying to turn those back into case studies and stories so that people don't lose sight of the people and the things that people go through, and so that it's a more people-centered. The other thing that we led on with the ICB was a big conversation, and that's where we went out and gathered insights from people across North East London. Actually, we ended up leading on the Newham bit as well. But so after we'd talked to all the people, we actually came up with this framework that was based on what people said good care felt like to them, and there was 4 pillars to that, and that was that it was accessible, person-centered, competent, and trustworthy. So it kind of fits within the art thing a wee bit as well, but access and trust are probably the 2 big things that have a really big impact. So we tend to use the good care framework in just about everything we do, and we can group the insights that we gather under those 4 pillars so that you can actually measure whether services are improving over time. So it's kind of evidence and data driven, but very much still people's stories. And the good care framework is now being adopted under the ICB's new system strategy. So it should be something that we can use across North East London, but I think Newham and Waltham Forest will be ahead of the game because we'll be able to do that. The other thing we do at the moment is we actually have an interface, which is a database, which is Power BI driven and everything, which can look at data across community insights and activity and look at population health management data and bring it all together. So I think that's another way of making sure that the community is really at the heart of some of the data-driven packages that the ICB is going to be looking at as well. And a real focus on inequalities and really looking a lot around detailed demographics and wider determinants of health. So not lumping every ethnic group or faith group or, together, but looking at things like housing and income and employment and as well, and trying to get down to a granularity where we look at don't look at South Asian or Black African and Caribbean when we try and dig down to particular countries of origin rather than lumping people together, because that doesn't help us much either. So that's a little bit about how we work.
Interesting. And have you kind of intersected with or interfaced with the Commission for British Futures and their work around, is public health involved in that?
not directly known.
That's fine. That's fine, we can pick that up as a conversation later.
We've spoken to them, we were part of their kind of induction, or some of us were part of their induction meetings to help them set up. And we introduced them to various community partners we thought they'd be interested in.
That's absolutely fine. We'll leave it there. Okay, thank you very much, Ryan. We look forward to welcoming you to more meetings and continuing your work with us. Thank you. Okay, moving on. Oh, so I'm happy to we accept that report. Can't remember now, so we'll go into one. Yeah? Yeah. People customer, or do you want to take a 5-minute break? Crack on? Okay. Next item on the agenda, item 7. Yeah, do dive into refreshments. Health, new health equity programme, an update from Claire, looking at 50 steps.
Thank you very much. So this is an item, this is our annual report. So this is our annual report to the Health and Wellbeing Board on progress in delivering 50 steps, which is, as you all know, our joint collective health and wellbeing strategy. Just to start with what our asks are of the board today, there are 2. One is to ask the board to approve the 24-25 annual report, and particularly noting not only the progress we've made, but the particular areas that require sustained focus. And the second ask is to commit to maintaining the activity and the partnership working that we've established not only over the last year of delivering the current strategy, but over the previous 3 years of the first version of 50 steps. To commit to maintaining that work across the breadth of the strategy, but prioritising that action where we most need it. So particularly for those outcomes where we're lagging behind or that are getting worse. So those are the 2 asks. Just to give a brief overview, it's a relatively long report. The first thing to say is thank you. There's been many people involved in putting this together from across our organisations, not to mention the work that's gone into actually delivering the work. So thank you for all of that work. The intention of the annual report is to present on 3 specific things. Firstly, the KPIs for each of the 50 steps, the equity objectives for each of the steps, and some set public health outcomes that we set out in 50 steps as our core set of outcomes that we would want to monitor over the course of the strategy. So the report aims to do that, and I think it's really important to sort of note that it does not attempt to describe the vast breadth of work that went on during 24-25 in delivering the strategy under each of the steps. So it really scratches the surface, but it was felt to be a sort of an effective and a suitable level of detail for what we're trying to achieve as in this board. So we have a huge amount to be proud of. Again, I'm not going to attempt to list all those things from the report. A few highlights or a few examples really. Healthy schools. We went from having 61 schools with a bronze, silver, or gold award to having 80 schools with an award in 24-25. Attendance at New England Recovery College, which is a mental health service, almost tripled in that year. We again continue to exceed our targets on health checks for people with a learning disability. And those are just 3 examples that I picked out from many of the type of activity that we collectively delivered that has real health impacts, whether those are immediate things or longer term, but they're all evidence-based. But really importantly, falling out of those activities, not just in that year, but in previous years, we're seeing improvements in some really fundamental public health outcomes, and that's what we're ultimately trying to achieve. It's not just the activity, but it's about, do we see that long-term outcome? We're seeing real improvements in smoking rates. Our smoking rates are falling faster than London and England averages. Physical activity among children, young people and adults has increased since 2019. Adult healthy weight has improved. We're seeing increasing rates of breastfeeding. Premature mortality from cancer is falling. And these are some of our outcome measures that we monitor as part of the strategy where we're seeing improvements. And it's really important, of course, to highlight that because there's lots that we can celebrate about the progress we're making because of the way we're working together. However, there are some other areas where we we really need attention in Newham. And some of these are really long standing as well. These are not new things for us. So children and young people's weight continues to be a challenge. We continue to be worse than London and national averages. Oral health outcomes in Newham are particularly poor relative to neighbouring areas in London. Breast cancer and cervical cancer screening rates are falling, so that's something that we want to address. Immunisations and work on other infections, that's a real priority. Again, some indicators there getting worse. And then another thing that isn't quite captured as clearly in some of these outcome indicators are some of those wider challenges that we know are affecting Newham more than other places. So, for example, homelessness, the effect of the cost of living, temporary accommodation, which is of course linked to homelessness. Some of these wider issues that are reflected in the strategy because it's a whole system strategy. So those are just picking out some key areas that we would propose that we put renewed focus on going forward. But of course that's in the midst of really significant challenges for all of us as organisations. So we have huge financial challenges. We've talked already about the sort of the restructuring in the NHS that's creating challenges in terms of being able to move forward, and other challenges beyond the boundaries of Newham. And so I think it's for us as a board to be able to sort of be open about where should we be focusing our resources, when we know we have these challenges, how do we prioritise as a board, I think is a really important conversation. So how do we go forward? So there's a couple of areas to highlight, one of which is not, I haven't specifically set out in the cover report actually, or in the document, but for those who don't already know, we have a 50 steps board which sits underneath the Health and Wellbeing board. So that's a board that meets quarterly to review progress on the strategy. One of the things that really came out strongly when we were putting together this annual report was the way that the strategy puts a focus on equity is really helping to shift our focus towards equity across a whole range of services. So we're talking about equity, we're focusing on it in a way that we hadn't done before in some areas because of the fact that we've set out those clear objectives in the strategy. And so what we've decided as a 50 steps board is that from now on, the thing that we will monitor most closely as a board will be the progress against those equity objectives, because they're specific, they're measurable goals that we've set that we can meaningfully monitor with the board. And they really reflect the breadth of the strategy, but particularly highlight some key equity issues that we want to tackle. So that's one way that we're trying going for this year, and then, you know, hopefully if it works going forward, that we'll maintain momentum and continue to improve in some of those areas. And then the second point, I suppose we've really talked about it already, is around how do we seize the other opportunities of things that are changing in the system. So we have the 10-year plan, we have our neighbourhoods work, we've already talked, Joe, about how we bring together the 50 steps commitments and our work on putting into practice neighbourhood working with the NHS. Got lots going on in the council in terms of what our priorities are, how we maintain that focus on health and wellbeing and equity as part of that. Will be really key. From my perspective, I think getting the basics right is key. In some areas, that's what we can focus on, particularly given that we have such financial challenges. We don't necessarily need to be continually sort of innovating and changing. It might be about actually, for example, through the health equity programme, taking a really hard look at what services are we delivering, how can we improve and get the basics right. Anyway, I'll stop there. But in summary, we've got loads to be proud of, really strong relationships and partnership working, and really clear areas that we can work on.
Thanks, colleagues, any questions?
I think actually, well done. The organisation declining. We know why.
Question. We're seeing it across London, so it's not just a Newham thing.
It's like since COVID, is there some connection?
It could be. One thing that is talked about a lot is a potentially a bit of a myth. It's not a myth, but I think it's overstated, is vaccine hesitancy. So what we know is that access to immunisations is by far the biggest determinant of whether or not people go and get their jabs. So is it a convenient place, convenient time, and so on. And so we don't fully know why certain types of immunisation uptake is falling, but what we think it's probably not being driven by sort of rapidly increasing levels of vaccine hesitancy. That plays a small role, but what we're focusing on in terms of improving, getting on top of that and improving the uptake is how do we enable people to access it more easily, essentially. And we're doing that through learning from all of the work that we did in COVID and since then, in terms of where do people go to get their vaccines? How do we make that as accessible as possible? What are the things that work so for example, one thing that we found is that people want to have a quality conversation with a clinician often about their vaccine if they're not quite sure whether they want to get it. And then if you can combine that with having the jab there and then on site in a way that you can have that conversation and then offer it there and then, that works really well. Our Aging Well Festival that we hold once a year, that's an example of that. We have people there who can have quality conversations and then deliver those vaccines there and then. And that works really well.
But it's definitely the case on Saturday. There was a nice little steady queue.
Yeah, I saw that as well. So that's a really good idea.
Any questions or comments? Online? You having the 80 schools improvement, Laura?
Sorry, councillor, say that again.
I was saying, are you happy with the 80 healthy schools that you've now got?
Yes, very, very. It's great. It's
tested
really
them?
great. Yeah, really been brilliant.
Good. What's to say? Sorry, Jack.
Yeah, sorry. Thank you. Did you want to say first?
No.
So yeah, I just you were talking there. So yeah, I think again, obviously we're part of this, and it's a great report. I was thinking through your question earlier around that most plan, but I think in what you've just been saying, there are things that we should be doing before then, and thinking about. So as part of the neighbourhood programme, we're thinking about outcomes. So we need to make sure that we don't have two sets of outcomes. Some of that aligns, that the equity objectives are brought into that. Also, how we, we're beginning to create locality leadership teams, and so how are they aware of what's in this, and where are we sharing some of that good practice? And we're thinking about probably in January holding some kind of, kind of neighbourhood type workshop for Newham. So actually bringing the health equity programme, I think would be a good opportunity for us to really embed it actually in the work that the neighbourhoods are doing.
We should have some clarity around budgets by that time as well, so we'll be able to with some certainty. And I will say that this, I think, was my second week in the role when Claire presented me with this, and I had looked at 50 steps before, but it's very different looking at it as a backbencher to looking at when you're meant to be leading it. So thank you to you and colleagues for all the work you've done on it. It is an impressive piece of work, and I think it's to everyone's credit that the dial's moving in the right direction, albeit with some bits of red, but that's life. And I think that whole point about vaccines and immunisation is going to be a piece that stays with us for some time. But knowing your data and going back to the previous conversation is so critical in these situations, and I think that's what this report's really good on. So thank you to Claire and colleagues. Are we happy to know the report? Yeah. And also to commit to maintaining our activity and partnership working across the breadth of the strategy, prioritising action on outcomes where Newham performs less than the London average. Are we all agreeable to that? Yeah. And I think Joe's already offered an opportunity in January for us to kind of extend that and dive a bit deeper into that. Well, if I've misinterpreted, thank you. Okay, moving on. Item 8. Martin. Does somebody need to get Andy ready, or is he?
Hello. I'd like to introduce Aisha Ahmed, who's our assistant strategist, who's going to do this presentation, prepare this presentation. Oh, you're looking at you. Okay, I might just keep talking. We'll do it together, okay. So this is an update on Wellbeing. So just as a bit of context, as Claire mentioned previously, one of the metrics that is not going in the right direction is around childhood obesity. There are substantial wider determinants, negative drivers in the area of childhood and adult overweight, which are seen in our persistently high type 2 diabetes levels, in our persistently high high blood pressure and heart disease levels, in our persistently high childhood obesity levels. We have a number of what are called food swamps, and they drive overweight much more than food deserts, which is an absence of healthy food. We have taken a strategically overarching approach to this, putting together the health promotion parts of the public health team and the food strategy parts to start to look at where we might be able to systematically move levers or think differently or to make change. Aisha's going to feed back on a part which is it's quite niche, but it's basically addressing challenges around the cost of living. We know that healthy food per calorie is more expensive than unhealthy food. That gap has been widening over the past 10, 15 years and continues to get wider. So where people are wanting to make a behaviour change around their diet and weight, often there are challenges around the affordability of the food. So we're piloting fruit and vegetables on prescription. And this is one of our a range of interventions. But Aisha, do you want to just set up the pack?
Sure.
Or
No, share my screen.
Or shall I can share it from here actually. So yeah, so that we've got a short presentation just up. Christine, could you let me share, please? No worries. Came late to it. So just to give an update on that, which is it is novel to do it for this, and then we can just also look at some of the other things. In a minute, I'll be letting you. Brilliant. Thank you very much. So thank you to Aisha for making the pack.
Thank you. So as Ali mentioned, we're just going to do like a whistle stop tour of the intervention that we're planning. So the context is that essentially we are a borough at risk of diabetes, and we have a lot of things which are driving obesity, ill health, and diet-related disease. Our diet is a leading cause of avoidable harm to our health. 10% of our population have type 2 diabetes compared to the national 7%. Around 27% of our residents live in the 20% most deprived LSOAs. And so we know that we've been told time and time again that the availability of food and access to healthier foods is a key driver in people not being able to make the changes that they want in order to better their health. Next slide, please. Oops. Yeah.
Yeah. Yes.
Okay.
Yes, you're right. No,
You just skipped.
yeah, I skipped off.
So yes, as I mentioned about affordability, so it is essentially very much healthier. It's very much more expensive to eat foods which are better. And there's a little diagram in the corner which sort of exemplifies that, about how the average price per calorie is so much higher for foods which are nutrient dense compared to those which are calorie dense but worse for you essentially. And 27% of new residents have to spend 50% of their disposable income in order to meet the recommended yeah, it's pretty astonishing. The recommended government healthy diet. And so yeah, it just really drives home the fact that we really need to be able to address food insecurity deprivation in tandem with our interventions. Next slide, please. No, that's perfect. Yeah. So the strategic importance of addressing diet-related disease, it's on the NHS 10-year plan. It's part of the GLA's strategies. There's a House of Lords food, diet and obesity committee, and of course it's mentioned in our 50 steps. So it's sort of across the board a very important piece of work, and it's on everyone's agenda. Next slide, please. Yeah, like I said, we've had time and time again from new residents that actually the thing that is driving ill health from diet-related disease is the affordability and the access. As you can see in bold, it says just promoting healthy eating, but actually providing affordable fresh fruit and vegetables is a key issue and a sort of desire from our residents. And in 2019, Health Watch conducted a research, and they asked what stopped you living a healthy life. And the top theme was the availability of unhealthy foods and money, price, and affordability of healthy foods. So it's really very clear that that is something that we need to address. Next slide, please. Again, this is a piece of work that was actually published very recently, based on work being done in Newham. And as you can see, the themes identified by Newham residents as causing unhealthy diets, a lot of it were to do with the sort of the physical environment, social, environmental causes. So our residents are also, this all fed in from our Newham residents based on interviews. So our residents are very much aware that actually it's not an individual, it's not a choice necessarily that they are, you know, leading unhealthy lives. That it's actually the greater and wider determinants which are sort of forcing them or leading them to sort of live their lives or adopt a lifestyle which causes diabetes disease. Next stop, please. Thank you. So we have the Eat Well Newham program, and I'm just going to go quickly through the Alexandra Rose voucher program. Next slide, please. I'm so sorry, I'm having to ask slides so often. So why adopt a fruit and vegetable on prescription model? So it's a community eat well model which has been recommended in the 2022 Levelling Up United Kingdom White Paper. That's a bit of a mouthful. And it's a really effective local intervention which has the potential to transform people's diet, reduce financial stress and food insecurity, facilitate trust and connection, invest in and create demand for local food businesses, boost community wealth, and ensure dignity and choice for those facing food poverty. It's been run before in Tower Hamlets, and they've had really fantastic results. With sort of the sort of slide speaks for itself really. That they've just had some fantastic outputs, as you can see. Next slide, please. And not only has it improved people's individual choices and sort of like their ability to sort of incorporate better foods in their diets and nutrient-rich foods in their diets, but it's also reduced pressures on the NHS, which is of course very much in line with what we've been speaking about, moving from community to hospital, etc., etc. Next, please. So it's a really the opportunity to do things differently. So it's addressing a known barrier, as you mentioned, that affordability and access is a key issue. And it allows us to sort of directly address and minimise these risk factors, which we know are harming our residents. And it's also the opportunity to leverage local knowledge of local organisations like Nutrition Kitchen, like our library teams, our community teams, to make appropriate referrals, combined with the technical know-how of our voucher partners. I will go through the model afterwards, just to clarify. To mitigate inequality, so with our previous diabetes interventions, we've actually had a huge inequities in the uptake and the attrition rates. So we found that a lot of essentially our South Asian communities, our Black Caribbean and Black African communities have had very high drop-off rates of our programs, and the fruit and vegetable prescription model has been really effective in sort of targeting our whole community, and it's been really an equitable intervention in other boroughs. It's also really allowing people to make real world behavioural change, keep up our, like most behavioural structures, frameworks, is giving people the opportunity and this to make change. And this is really handing the opportunity back to residents, also maintains autonomy. And it's a really dignified way of sort of making change quickly. Can we next slide? Thank you. So the Newham offer. So the NEL ICB has funded 12 months of the fruit and vegetables on prescription pilot. But so we received £50,000 from NEL ICB. So this isn't any extra cost to the council. And so the basic model is that we partner with the Alexandra Rose, who are the voucher distribution partner organisation. And they offer 2 cohorts of 45 people, so 90 households in total fruit and vegetable vouchers on a weekly basis. So if you are diagnosed with diabetes, you have a deprivation need, and you are in walking distance of either East Ham High Road or Queen's Market, you're eligible for the fruit and vegetables. And the idea is that we give £6 per week to the member of the household with diabetes, and plus £2 per member of the household. And it's ring-fence spending to only be spent on fruit and vegetables from those given vendors. And it's a really great way of also sort of putting money back in the local economy. So it's 6 months per cohort, and alongside the provision of the vouchers, we also offer monthly sustainability resilience workshops, where we sort of look to give the participants the skills to maintain healthy behaviours once the provision of the vouchers has finished. So essentially just to ensure that there's no cliff edge, and that people feel like they have built-in sort of skills to continue to live a healthy life. And as it is a pilot, we are only working with Central 1 PCN, because those are the social prescribers that we're working with, and the distribution will be from East Ham Library, Class A Library, and Main Street Library. And the community neighbourhood team and the library staff have been great, and will be supporting us as distribution partners and a point of contact for the participants on a weekly basis. Next slide, please. So this is sort of like a very brief overview of what I just mentioned essentially. So a social prescriber nominates a resident based on criteria. Participants collect a weekly voucher of £6 per week plus £2 per member of the household. Vouchers are distributed through the libraries. Vouchers are only spent on select vendors and only on fruit and vegetables, and then they attend a resilience workshop on a monthly basis. This is sort of the timeline in 3 phases. So we have at the moment we're undergoing the training of library staff, identification of residents, and nominations from the social prescribers from the Central 1 PCN. We're developing an evaluation framework, and we're identifying local outlets and markets to partake. In November, we will be starting with our first cohort, and the second cohort, there'll be an overlap of 2 months, and they'll be starting in March, if I remember correctly. And then the 4th phase is delivery, closing, evaluation. Next slide, please. So as I mentioned before, we're really hopeful about this intervention, and it has great potential to be a really equitable intervention. So as I mentioned, we had very high attrition rates from our key communities. So as you can see on the side, that pie chart shows sort of the prevalence of type 2 diabetes and which ethnicities in the borough. And so we are looking to we've made a concerted effort to essentially ensure that we are cross-referencing and sort of meeting the we are what's the word I'm looking for? We're nominating participants who have historically had very high attrition rates, but also those who are at risk and who have very high prevalence. So those target groups are the Bangladeshi group, Bangladeshi community, Indian community, Pakistani, African, White British, and Black Caribbean communities. And this will be in addition to the nomination criteria, which I mentioned before, of being in walking distance to one of our chosen vendors, having a type 2 diabetes diagnosis, and also having a deprivation need. And yeah, our key outcomes are looking to increase consumption of 5 days of fruit and vegetables, 3 of which are vegetables, to reduce blood pressure, reduction in HbA1c, which is also known as blood sugar levels, and an improvement in well-being per survey. And that's everything.
Thank you very much. I'm still getting over the shock of 27% of residents. That's a shocking. So I mean, I do not in any way wish to kind of minimise this. 90 cohorts at a time of 50,000 isn't even gonna stretch it, is it? If we've got that level of need, but that's not all diabetes either, is it? That 27% is not all diabetes. Yeah. Okay. Right. Questions? What do you need from this board?
Just want to let guys know it's happening.
When did the pilot start?
So it's starting on 16th of November.
It
And then
started.
the cohort, sorry, it started in August,
Yeah.
and the first cohort starts on 16th of November, sorry.
And I presume there's no problems around referrals or anything coming.
So far, no, yeah.
And Councillor Carter.
Thank you, Chair. Yeah, it is an amazing statistic. Does kind of rock you back a bit. So clearly, it's a targeted piece of work. It's likely to be quite effective for the people who are receiving it while they're receiving it. Where do you see it? It's pilot, but where do you see it leading to? Because it costs, doesn't it? And as Chair said, it's powerful for those people, but it's a drop in the ocean for the community as a whole. So what do you see coming out of it
So
in that sense?
one of the things is a proof of concept, particularly around using vouchers. We often hear that vouchers are stigmatizing and that people don't like using them. But Andy did tell you that a number of government programs around food security or food delivery, or they use vouchers. So it's a way for us to be able to test out how to make those as acceptable as possible. We recognise that it's small numbers, but we've structured it, or I should have structured it, to be able to bring the whole family along as well. So we're not if you go as a single patient or person with a condition within the usual NHS architecture, that the support services talk to you in isolation. And actually, we've got some feedback from some master's students that people would like to be able to bring family members with them. So what we've done with this is we've built the support around the household. So the idea we're trying to build a household intervention. So those two bits of proof of concept to see if we can get more value that way, so that we'll be supporting better eating throughout the whole household, building the resilience around what happens when it ends, and building the relationships with the vendors is a way to look at being able to support people to continue to eat more healthily. One of the things that comes into this is finding those ingredients that are the most cost effective and still healthy, and right up there are things like pulses, so that even though everything has got more expensive, there are still ingredients and ways of preparing those ingredients that can be more cost effective than being pulled back towards the takeaways or the fast food or the ultra processed food, or more importantly the refined carbohydrates like pasta and rice.
That's what I was trying to understand really, because the underlying problem's still going to be there.
Yes.
So you're hoping there's an educative element, but also and part of that is kind of finding cheaper ways of maintaining some of this.
Yeah. The other thing about this is that the PCN. So one of the things is also in the original idea is to be able to support people to be able to complete one of the NHS commissioned services like the Pathway to Remission programme. So Central One has the highest referrals into that. We know that these communities have the highest attrition from it. It is not culturally tailored. It starts with meal replacement, and actually there's national data showing that Black and Asian broadly communities or communities that are not white Anglo-Saxon, they don't particularly like the meal replacement element. So real world foods, making healthy real world foods accessible and affordable, is quite important for these communities. So it's a proof of concept. We recognise it's small, but I think we need to be able to bottom out some of the understanding about how this could potentially work, to be able to tie it to some of the other parts of the programme, which are around sort of dietary advice, recipe advice, portion advice, etc.
Yes, Carl.
So I love it, by the way. It's different from how we hand out vouchers in other, perhaps following up with education, and it's not just like a matter voucher. How are you advertising, or how? Where does your referral come from?
So yeah, we are being quite tight with the advertising of it, because it is limited to one PCN, because we only have on board. At the moment we only have a group of social prescribers from one PCN who are able to make referrals. So we are actually only advertising it through one PCN to the GPs social prescribers and sort of allied health professionals within that one PCN, unfortunately, because we only have 90 participants. So we are trying to keep it a closed circle.
If I should have come in and say something on the what's next, it would not be the first time that something had begun in Newham or begun in Newham and Town Hamlets and had gone really, really big. Universal Meals began in this borough with us taking a chance on something that could really make a difference back in 2009. Obviously, we've seen that scale London-wide based on the evidence that was produced by somebody making a difference with it. And there's a, in terms of everything begins somewhere, doesn't it? Somebody taking the right.
Well, absolutely, but I think my principal concern would be with the residents rather than you getting any glory out of this.
For more long-term funding.
Well, that aside, but it's also a cultural change as well, to be able to embed that type of thinking. Because, I mean, I'll give you an example. I work in Waltham Forest, and one of the things that stunned me was somebody from Public Health there said to me that they were seeing an increase in men needing expensive care packages from the Caribbean community, and they couldn't work out why. And it was actually because they were losing their wives earlier on, then self-isolating and not cooking. And the intervention response, which I thought was ingenious, was they bought them air fryers and showed them how to use air fryers for healthy cooking. And that's actually set that cohort up. And very, very slowly, they're starting to see their expensive care packages coming down. But that's a really kind of, Waltham Forest has got the Marmot report, they're kind of well embedded in that. And it seems to me that we're trying to think as creatively as that as well. One thing I'll just bring up, and this is a personal hobby horse, so, but I do say this publicly, both in my writing and in where else, the word resilience. We use it a lot, and it might be a bigger discussion for this board at another time. Are we comfortable with the word resilience? And I'm not meaning to put anybody in the spot, but I will say the concept of resilience always presumes that it's the individual who can make the difference. When actually, when we know around race equity issues, is that sometimes there are structural inequalities out there. So just something to bear in mind there. I don't want to open that can of worms.
No, I mean, it's good. I think I've seen some fantastic graffiti in Belfast around the problematic use of resilience. Yeah, we quite have to change the words. I think one of the real challenges around diet, weight, diabetes is that most of the narrative is around individual behaviour change, but it's set against the landscape of an awful lot of wider determinants drivers, and structural racism is also one of them. But ultimately, individuals have to be able to negotiate that, and we can give them support. They have to be, and I think we have to have different models of support for almost like a 12-step addiction type of model of relapsing and remitting type progress through this. But I think we can't just kind of put people into a 12-week weight management program or a remission program that says, off you go, there you go. I think we have to acknowledge the context, so that's what we're trying to pick apart with this, and also to mainstream as many defaults as we can in the healthy direction. You might have noticed some changes in the Dockside Diner. So across the remit of where we have reach, influence, direction, input, we're looking to be able to shift the dial on foods that are going to be more health promoting and less health harming, and making those accessible and then acceptable and then.
And how do you feel the work is going? Is it where you want it to be? Is there anything partners around the table can do to help?
Well, no, I think it's going fantastic well. I think every step there's been real buy-in from every stakeholder. People, like it said in the report, people are crying out for this, and this is something that residents really want. And what was really stark to me in that report that I cited was that people are very aware of the wider determinants at play, and sort of understanding that actually it's not really a choice that people consciously make, that actually they're a product of their environment, and that this is absolutely something that people want, and it feels like it is very sort of gratifying in that we feel like we are meeting a need when we are talking to people, and the social prescribers are sort of having really good sort of conversation with people, and people are really welcoming it, which is always fantastic to hear. So yeah.
It's just inductory. Is it still 5 a day? That's the government's recommendation, not 7 a day. It's still 5 a day.
It's still 5 a day, but sorry, there's a professor at Kew. The evidence base really is that to make a big difference on how long you live and how well you live, you probably should be eating in the region of 8 to 10, mainly green leafy vegetables. Sorry. So, but the government said did 5 a day because it's achievable.
And actually, for the purposes of our work, it's probably more affordable and we'll get more.
Yeah.
Yeah.
There is something else in this that so there's another thing we'll bring back another time. That so I also have to congratulate Aisha on the hard work she's done on this. She's done most of the heavy lifting. Yeah, all of the heavy lifting. So that's brilliant. So thank you very much. Congratulations. But also there's a companion piece around how we support people with food and diet advice, which will come along. That we're thinking about that in two forms. We tend to do diet advice that for a maintenance, as though you're already well, but actually 70% of the adults in the borough are already overweight, so that we need to be able to support a more intensive version. And there are some, the remission diet is very intensive, but how we land that and make that possible for people is a bit more of a challenge. So that we want to think through that as well.
And there might be some thinking and ideas that come through this.
Yes.
As well. And could there be a link to exercise and prescription as well?
Yeah.
Is a way to encourage people to go to GLL as well?
So actually the exercise and prescription is something that time and time again has come up from our, like, we have a diabetes support club and the funding for that is sort of incurred. So yeah, it's something that we would definitely welcome that, because that's something that our residents are really keen to sort of get back on the agenda. Yeah.
But I was thinking in terms of longevity,
Yeah.
making sure people stay healthy, and the idea that actually it's a family intervention helps people as well with that kind of social.
Yeah.
Any other questions before we move on? Thank you very much and congratulations, excellent piece of work, and yeah, we'll look forward to hearing the next iteration of it and the feedback as well. Thank you. Colleagues, the last item on the agenda, we're nearly there. That's not to rush you, Andy. Item 9, food security. Oh, sorry, and we have to know the context of the report. Would you be able to share the presentation as well? Thank you very much. Food security. Andy.
Well, thank you for having us, and yeah, we will be fighting partly because over the last 5 years, this matter and some of this has been specifically back to this in several different ways, but always building around the same. There we go. We have been fantastic. Always building around the same fundamentals because of some things that we're going to talk about tonight that we put in train very early and have served us in good stead. So we might feel and get that on the screen. There we go. I'm Andy Gold, head of food strategy.
Hi, I'm Mark. I'm Public Health Team Community Partnerships Officer for the New Food Alliance.
And we're going to talk about the New Food Alliance tonight. And you've seen it before, some of you, the famous mighty sandwich way of working, which was a really lovely way of describing what we do for one of the church leaders. And we've got some fantastic orators, as you might guess, in a network of 40 imams, priests, football coaches, and the count in the middle, we have 40 community-based organisations providing the ground game, food clubs, food banks, and community hot meals. And then the council does 3 things around that. So there are in fact 3 bits of bread, but let's pretend there are 2. The first thing we do is through the Social Welfare Alliance and other support, we make sure that all of those ground game operations are all about wraparound support, are all about using food to work with residents to get them beyond hopefully the need that is driving towards seeking direct food support in the first place. Then the second thing around that is we've had to operate at scale since the very beginning. Data last year shows that we're still working with, or to the most recent snapshot data, and data last year shows we're still working with 4,500 households a week. Years after COVID response, and then obviously what we really narrated as cost of living. This is still ongoing in Newham, it's still happening at scale. And the way we've done that is using surplus food. Now, the council does 2 very important things around surplus food. Firstly, we support with some of the logistics. We use what is currently Household Support Fund. We've always used it to produce fishing rods rather than fish, i.e. the logistics of using a lot of surplus food. And around that also a lot of support with understanding what surplus food is and that it's good food that is falling off the food ladder. And obviously using this makes people like Jacob and the climate team, that team, very happy. But we didn't do it for those reasons back in COVID. We did it because the scale of need in Newham was enormous, and we needed to find a way to work with what the food system was giving us. And so that's been a really big part of that. And then the other piece of bread at the bottom that's really, really important to how this works. The Newham Food Alliance front door, again, talked about in the paper. Again, since 2020, we realised very, very early on that there was a really important coordinating role. If you could get residents to the right organisation, we have a tremendous spread of organisations in Newham involved in Newham Food Alliance by geography, by faith, by food culture, by specific social issue or specific area of expertise. And if obviously when residents reach out for help, you can get them connected with the people best able to support them. It makes the whole network more effective. And that's proven to be a really effective and long-standing thing as part of a really big joined up approach to food security. All of the things on that list, we're talking about Crisis Resilience Fund, I would suggest are well positioned for what comes next, because since day one, the focus on food security in Newham has been using food to connect residents with things that will make a difference towards getting them beyond the situation they're in at the moment, or the situation that's driving them to seek help. And each of those programs could come and talk you through what they're doing. The big change at the moment is, along with some other really helpful bits of long-term sort of funding confirmation from central government, holiday activities and food. That's a really big and important piece of news for you. I'm hearing that's being extended, and building on the most recent household support fund extension. Government has announced there's going to be a multi-year community resilience fund at about the same scale as the household support fund. The thing that is going on, and where there is some really serious dialogue at the moment, is around what the guidance and guidelines for that fund is going to look like, what the conditions are. And we're actively involved in that dialogue. We've been asked at certain times to feed in things very directly, and we're involved with some really, really important regional and national partners like Feed and Green, the GLA, again through London Council, Sustain, to make sure that again we are working to help shape those guidelines. We don't know what the final guidance will look like yet, but we have had a lot of dialogue and some steer. And the feeling is that for things like annual money, but particularly for the Newham Food Alliance, we feel like we're in a really, really good place with what's coming next. The way Crisis Resilience Fund is being talked about is there's a big focus on doing what's been done with household support fund, giving it to local authorities to use as they best see, but with the best see fit to make a difference, the best target support, but with a real focus on, and these are the government's words, not mine, resilience, but really making sure that there is a strong advice infrastructure, that we are being preventative, that we are working with other anti-poverty strategies to try and move residents beyond the need for direct food support. Specifically, the language of food clubs is being used. And food clubs is, we have a London leading number of food clubs in Newham because we recognised really early on that we wanted, again, that wraparound support, or things that had a focus on a sustainable and managed approach rather than the idea of food in emergency. Ending the mass dependence on food banks, again, something we've been talking about in Newham since the very beginning. It's not an acceptable way, is it, for residents to get their basic needs met? And so that's something that we've always been working towards. And again, that focus on rapid assistance and prevention of destitution, and acting early so that things don't spiral and get worse by the time you act. And there are some things that will be scaled down over time. So it's been noted in the early dialogue that things like school holiday vouchers, where they're seen as perhaps not that ability to give the same wraparound with a voucher. Some of the dialogue is suggesting that might be scaled back in terms of the guidance and where the expectation is. One thing that is noted that we're really pleased with is the dialogue so far suggests that government really recognises that role of coordinating, organising, that thing that we've done in Newham since the beginning and is now getting taken in-house by one or two other councils. It's going to be valued by the fund. And if that sounds quite familiar, well, this is what we set out to do in 2020. And very early on, we realised that we needed some strategic outcomes to make this work impactful. And the thing that we talked about was, can we mobilise those trusted places to mobilise those trusted places in the community to get residents to, yes, accept food support, but with it, that wraparound support. In Newham, we do food banks, food clubs. We've got about 24 food banks, and I'd say about 80 to 85% describes food bank plus with real wraparound support in there.
Yeah, 80.
And so a really big focus. And we're going to talk in more detail about community hot meals because it really draws out the way all this works. Just very briefly to talk you through last year's phase 4 of that programme, this year's phase 5, because it really draws that out. But there is a really, although there's a long way to the dialogue being finalised into that guidance, there's a thing at the moment we're really well positioned because what government are talking about is what we've always been talking about this work in Europe and what's been driving us now for 5 and a bit years and has been a really, really important part of what we do. Food clubs, obviously, where there's a small membership fee, paid each week or members contribution paid, and a real focus on those clubs being member led and member driven. And again, to talk about something that Adiola mentioned with the last item, that idea of things that have dignity and are all about, you know, a community making a difference, and particularly with food clubs, that emphasis on stopping food falling off the food ladder is as much about food waste and our responsibilities around climate and the things that we can do to be efficient within the food system as the need to feed people. I'm not going to click you through all of these slides, but I will circulate them. And they talk in more detail about those things that are in the paper that are fundamental part of the work. We've always obviously worked hard to campaign and to escalate on this issue. Surplus food is talked about, and again, we've always put a really big focus into making sure that inside the new food lines, it's about organisation of all the pieces of the puzzle. It's not enough just to be in a position to run a food bank. You have to be able to do it with all of those elements to make a difference. And again, that idea of a group of partners who want really good governance for themselves.
What's in it, Fanny?
And your food lines.
Right.
But I'll circulate those slides. And very briefly, I want to talk to you about the Community Hot Meals programme. And Malak, I'm doing something unreasonable. I'm going to show some slides of the scene. Would you go through how it works while I do that? And I'm sorry, this is unreasonable this hour when we've been for a couple of hours, the slides that they're going to take through.
Yes, the Community Hot Meals program does exactly what it says. So the New Food Alliance partners provide warm meals and warm spaces. And the key thing is that meal is the gateway to accessing further support. So the way the New Food Alliance works has this kind of strategic outcome at the end of it. So at phase 4, we had 18 New Food Alliance partners delivering over 20 sites. We had really good geographic coverage across the borough. And we had a big range of delivery models. So some had sort of sit-down meals during the day, during the evening, during weekends. Some had a cook-yourself model that was really important for asylum seekers staying in contingency hotels to get access to a kitchen to cook for themselves. And we were really happy with the monitoring and evaluation data from phase 4. And we had, 56,000 meals and over 4,000 signposts and referrals with those meals. So that just shows you every time a resident comes to sit at a community hot meals, it leads to further wraparound support.
Yeah, it's a really, that's not that slide, is it? A really broad range of support referrals are available across the sessions. And that's the statistics pick up on. Malak just mentioned it. So it's 4,600 households. And on phase 4, those 56,000 meals led to nearly 3,400 signpostings and referrals. Now, the amazing thing about that's 1 in every 17 plates of food served is leading to a resident being put in a position to take action, something happening. And that's the strategic goal here. It's summed up really, really well by, and that can be everything from support with housing, citizens' advice, baby bank, domestic violence, health referrals are really big. Malak, you might talk us through a couple of examples in a minute. There's a particular way that one of the partners described this that really resonates. And it's the idea that what we're working on is a first we break bread principle. So food is the foundation of the ability to do this work. We know that austerity has stripped out some of the tactility and time from public services. That's been a really hard thing, hasn't it? It's the same well-intentioned people trying to work just as hard with less time and resources, one of the consequences. And one of the themes of the New Food Alliance is how do we work as voluntary community-based sector partners in council together to put that tactility back in so that people are in a position to hear something they trust and take action, see something, take time to digest it and be able to take action. And it was summed up as first we break bread, food is foundation. The thing we're building is not the food, is it? It's action that improves people's health or improves people's situation in the long term. But a really, really beautiful summary, and I think the same person who came up with the Mighty Sandwich. So there's a bit of form there in some fantastic writing. Malak, do you want to talk us through just a few of the case studies, examples?
Yeah, well, we have a really big range of case studies from sort of medical outcomes to other outcomes. So we have examples of a resident going to community hot meals and then getting encouraged to register with a GP for the very first time. Another resident who had some concerning symptoms, and when they opened up about it to a volunteer at the community hot meals, was referred to a health check and was found that he has undiagnosed type 2 diabetes. Another resident who had issues with a solicitor and had an unfinished sort of immigration case for 10 years and was able to get a referral to Praxis and was able to restart the sort of home office application. or another resident who was struggling with finding work and was referred to our new work to go to a CV writing workshop and was able to sort of get support with the job process again.
And then really there were two asks. I'm going to circulate a slide. The two asks to the committee were obviously one to note, and the question I've been asked a few times in different settings, but not yet this one, is how we position the Crisis Resilience Fund. Well, we think well, and obviously there'll be a further update of the guidelines and not exactly as we now hope for and expect. And then the second thing is obviously just to be really aware of this as an opportunity. They are incredibly tactile spaces for obvious reasons. We will listen to our priest or our imam or our football coach in a way that perhaps, you know, when we're talking to the machine in different ways that provides all those services we need, feels very different. And it's a real opportunity, and we continue to want to push the boundaries of it and put everything possible in those spaces where action happens.
Thank you, Brendan.
Just cut off, has it?
Looks like it, they're frozen.
Oh, can you see anything? I can't see
No,
them.
they just suddenly cut off. They were mid-flow.
Unless it's one of those, does it just cut off?
Because
Well,
it's due to finish at 8:30, isn't it? So I don't know.
yeah, maybe I'll go and have my dinner a bit earlier.
I know, that's what I was thinking. I'm starving. It was all that talk about healthy eating and fruits and vegetables and everything. And I was thinking, I haven't had any dinner, I haven't eaten.
I think we should take the opportunity to
Yeah.
go.
Yeah.
Yeah,
I agree.
I'm going to.
See you
Thank
later.
you.
It's been a long day. Take care.
Exactly.
Bye now.